I think quite okay. You guys can answer the question quite well. Question one, no problem. The most of you stuck at question number two. Hmm. I think some of you still cannot don't understand how to count the heart rate from the ECG, is it? Because I think only half got it right. The other half, either you guys didn't count the heart rate, or you give a wrong answer. Hmm. Okay, never mind. I think ECG will have a few more lectures in the future. Right. I think let's start the lecture for today. So for these few weeks, we're still talking about. You guys see the full screen, right? Yeah. Okay. So for this next few lecture, we're still talking about lung condition. So mainly today we focus on bronchial asthma and also COPD, which is one of the very common disease that we're seeing daily in the ward. Right. Basically, in the airway disease, we can broadly divide it into restrictive lung disease and obstructive lung disease. Restrictive lung disease means that the condition that prevent the lung from expand properly. That's why restrictive. But we are not talking about this today. We are talking about obstructive lung disease, mainly affecting the large and smaller airways. It's a disease that causing obstruction of the airway means that preventing the airflow from in or out of the lung. And mainly we're talking about COPD and asthma today. Right. So what we start with bronchial asthma first. What really is bronchial asthma? So I think have a friend with asthma holding an inhaler in the pocket. We may even have a nebulizer nap because when you are during the childhood. So does that mean they are asthma? So they may or may not be asthma. Asthma sometimes is not so easy to define. Some can be very prominent, some may not. It's really there's no single test that can single blood test or single lung function test that can tell you that, oh, you do this test, you are positive, you certain threshold, you are asthma. It's not really like that. So bronchial asthma is more like a spectrum of disease. It's a chronic. It's really diagnosis is mainly by coupling the tally with the history examination and also correlate with the relevant lung function test. Then only will come out with the diagnosis of bronchial asthma, and the definition or the diagnosis may change down the line if the symptoms change. So basically, a chronic inflammatory disease is caused by inflammation of the airway of the lung. It characterized by this something called bronchial hyperresponse. Means your bronchus is very responsive to something. What do we mean by that? It means by the airway is very tendency to narrow, especially in response to different variety of stimuli that provoke little or no bronchoconstriction in person without airway disease. So, for example, allergen like smoking. So, some people, normal people, they do not have response to you walk by someone with cigarette smoking, they're well. Someone with airway hyperresponsiveness, they will cough non-stop. Even after they're exposed to smoke, they still will cough for a minute or two. Or even during the cold stimuli, especially after a rain or aircon room, they'll have symptoms like cough, wheezing, while normal people do not have. That's what we define as a bronchial hyperresponsiveness. And they will tend to develop episodic acute asthma exacerbation characterized by cough, wheezing, and shortness of breath. They'll have wheezing sound during the attack. And this acute attack is actually usually reversible. So the symptoms will improve with a bronchodilator. So asthma is someone who is who has tendency to develop airway responsiveness after they're exposed to allergen. They will have asthma attack on and off, and this attack reversed by bronchodilator. That's how we define asthma. Okay. So what is the etiology of bronchial asthma? Why certain people will develop asthma while other people do not? You notice those are smoking. Most of them do not have bronchial asthma, right? They're exposed to allergen every day. So why does it happen like that? Because asthma is more like a combination of your genetic and also environment factors. So genetic make up a large component of this etiology. So your genes define how your body responds to certain stimuli. So and mostly they are inherited by parents. You may inherit half from your parents, from your mother and father, or you may even inherit all of it from one parent. So, and of course, not just genetics. If you have genetic, your parents are asthma. If you don't have enough environmental stimuli or factors that trigger it, you may not develop the asthma as well. So it's combination from your genes and environmental factors. Okay, so like I mentioned just now, so the genetic factors not just make you to have asthma. There are other associated characteristic as well. So you tend to have airway hyperresponsiveness. You also tend to have atopy symptoms, where you get very easily irritated by cold weathers, aircons, and smokes. You also tend to have some skin problem, especially eczema. Those are commonly associated with bronchial asthma. So those who have a common or frequent exposure to allergen, be it indoor and outdoor allergen, occupational smokes exposure, air pollution, those are the group that tend to develop asthma earlier. Okay, so yeah, this is the common asthma trigger that we're seeing. Pets is still something very common, especially cat or dogs at home. Then insects at home, any pesticides. Pollen not so common to see in Malaysia because not too many flowers around.
Sorry, doctor.
Hello.
Are you moving the slide?
No, I. How about now? Can you see the?
Yes, doctor.
Yeah. Yeah. So basically, I think this is just a bit repetitive from this one. So basically, asthma triggers there's we divide into those that you can modify and you can't modify. So modifiable triggers is something that you can avoidable. And for example, smoking, pets exposure, uh, those are chemical fumes. Those are something you can avoid. Unavoidable risk factor will be triggers will be like pollution. Those are something you can't change yourself. Cold air, that's something you can't change. Pollen as well, but you can try to avoid them by going some other place. But the pollution is huge enough. There's no way you can avoid that. Okay. Right. So what happened in the bronchial asthma? What are the pathophysiology of it? So in someone who have bronchial asthma, when they're exposed to this exercise, allergen, or cold air, they will stimulate the one of the cell called mast cell and eosinophil. So when after they stimulate the mast cell, this mast cell will increase the eosinophil release from the body. All these actually triggered the increase in mucus secretion, causing increase in bronchial constriction and further eosinophil recruitment. So this is a vicious cycle. So once the allergen triggered the release of the mast cell and triggered the increase in eosinophil, the process is causing the target end organ increase secretion, increased bronchial constriction causing the narrowing of the bronchus. All this causing airway obstruction. Okay, so again, and you have a trigger factor, you increase in your chemical in the mast cells, increase in eosinophil, it causing the airway inflammation, causing increase in the mucus, increase in the muscle constriction, and causing the swelling of your bronchial membranes. All these narrow the airway. That's why you have the wheezing sound. That's why you have the cough and shortness of breath. Okay, so this is important. Sometimes we can put this in MCQ. Okay, so this cross-section image can help you to understand more. So image not so clear, but I think you can see here, this is a cross-section of your bronchus airway. Just take a one cross-section of the airway. Airway is like like a windpipe. It's like a plastic pipe. But in the pipe, there are different layers. So the innermost is your mucous membrane. So the secret mucus to lubricate and to moisture your airway normally. And then deeper inside, you have a muscle layer, the deep red color. So when you have asthma, the mucous membrane increase secretion. So you narrow the airway. And then you further worsen by bronchoconstriction. That's the result you get. Okay, everything become very narrow. The normal airway is like this, and then when abnormal airway, usual asthma airway already narrow. When they have an asthma attack, that's worsened by bronchoconstriction, the airway become very narrow. So all this causing chest discomfort, hypoxemia because reduction of your oxygen supply. So the common symptoms is wheezing,
Doctor,
cough, and shortness
sorry.
of breath. Uh,
The slide is
ah,
still not moving.
oh, really? Let me change to where is the slide that you're seeing?
Currently, you are talking about asthma in the airways, but it's not in the symptom of asthma.
Let me share the whole. Okay, now it's the symptoms of asthma, right? Right. It's many people having different symptoms, correct? Are you seeing this one?
Yes, doctor.
Yeah. Okay. Yeah. So common symptoms is still wheezing, cough, shortness of breath. Um, uh, and most commonly, they still, if the disease is severe enough, they'll complain of difficult breathing, they'll complain of chest pain, tachycardia, and shortness of breath. All those are actually it's your body compensation trying to improve the oxygenation because when your airway is narrow and constricted, the amount of oxygen getting to the body is reduced, isn't it? So your body want to compensate that feeling that I don't have enough oxygen, so I need to work harder. So your breathing rate will increase. You start to have shortness of breath. Your heart need to pump harder because you don't have enough oxygen. So you have a fast heart rate, you have tachycardia. Uh, and then when the airway is narrow enough, you trigger other symptoms like persistent cough and also wheezing. Okay, so let's say the gold standard in diagnosing this bronchial asthma is mainly based on combination of history and presence of the airway irregularity. So what do I mean by a detailed history? So we want to know is this common symptoms of asthma, like cough, chest tightness, and shortness of breath. Those are the common combination of symptoms you want to know. We want to know is there any symptom variability or not? Episodic symptoms or dural symptoms. So, what do we mean by dural symptoms? Is that the worsening of symptoms when the weather change, when they're getting cold. In bronchial asthma, symptoms tend to worsen when they are changed in environment into a cold condition or when they are changed when exposed to something. obstructive airway disease, especially asthma, you want to know, importantly, are they using accessory muscles to breathe or not? So the accessory muscles we're talking about will be your neck muscles, sternocleidomastoid muscles, and intercostal muscles. If someone is very tachypnic, you notice the movement of the muscles. And then the hyperinflation of the chest, you see barrel chest in someone with chronic airway disease. Audible wheeze and wheezing or bronchi on auscultation. Most commonly, you identify patient is tachypnic when they have bronchial asthma attack. They breathe faster, and you hear wheezing on auscultation. Okay, so what type of investigation do we do for bronchial asthma? So we're talking about this obstructive airway reversibility just now. So how do we objectively measure the reversibility? So this is what we're talking about. The test we are using is something called spirometry. So this is the machine for spirometry. So what we measure is something called FEV1, forced expiratory volume in 1 second. So if you see from this machine here, we will ask the patient to take a deep inhalation followed by a very forceful expiration. Breathe out, expire through the mouth in 1 second. So if let's say in normal people, your airway is normal in size. If you blow hard in 1 second, you get a good number. You get a good number. Probably you get around 4 liter. Okay, so if someone with restrictive airway disease, obstructive airway disease, the airway get narrow. When you try to blow out through a narrow airway, the amount of air, of course, will be reduced, isn't it? So your FEV1 will reduce during your asthma attack or when you have chronic asthma. So if you give a bronchodilator in someone with asthma, the muscles, the smooth muscle will relax. So this will open the airway a little bit. So when the airway is opened a little bit, your FEV1 will improve, isn't it? Because the amount of air expired out in 1 second actually increase because of your airway get bigger after the bronchodilator. So that is the logic behind this test. So when you give someone with bronchodilator, the improvement in FEV1 more than 12% means that it's a positive bronchodilator reversibility test. Okay, so that's how we check for reversibility. Of course, there will be other smaller, more specific testing, like the phenol testing, blood eosinophil. I think that one is okay. You don't need to remember this. You just need to remember the FEV1, the reversibility of your FEV1. So other important tests, of course, you want to do a chest X-ray. If someone with bronchial asthma, at least a baseline X-ray. If they are in the acute attack, X-ray is important to make sure there's no consolidation, there's no concurrent lung infection. You want to check the sputum and blood culture if you're thinking of pneumonia. Arterial blood gas is important here when the patient has at least moderate or severe bronchial asthma. So arterial blood gas means that you're taking blood to check the saturation of oxygen and carbon dioxide in the arterial blood. That's what we mean by arterial blood gas. So it can measure the total amount, a relative amount of oxygen and also relative amount of your carbon dioxide in the blood. This will tell us patient having respiratory failure or not. Other simpler blood tests, a full blood count to check for raised white cell count for infection. Okay, so what do we mean by how do we manage asthma? So our goal of asthma management is number one, of course, we wanted to control the patient's symptoms. We do not want the patients have any symptoms that restricting their life, that affecting the quality of life. So how do we define that? We define the control by no symptoms at all, no restriction of activity, good lung function, not using the reliever. Reliever means the bronchodilator. You see patient with asthma holding around the salbutamol blue color pump. That's what we call reliever. So good control means no using reliever in at least 1 month, no symptoms and no restriction in activity. And of course, in the asthma management, besides symptoms control, we want to reduce the risk of exacerbation. Okay, this is an important slide. I think question can come out in your long essay question will be discuss the principle of management of asthma. Then you talk about this too. Okay, so of course we want to reduce the exacerbation risk, and we want to reduce the dosage of medication to prevent side effects. Okay, so this is one way. This is one of the questionnaire taken from GINA guideline. GINA is one of the worldwide practice guideline that we use to manage bronchial asthma. So what do we mean by absence of symptoms? What symptoms that we particularly interested in? So there's 4 important questions that we need to ask when we see asthma patient. Number 1, do you have daytime symptoms or not? So daytime symptoms mean that the shortness of breath, chest pain, or wheezing that happen during daytime. So especially in the morning. So there's daytime symptoms. Want to know does the patient has nighttime symptoms or not? Nighttime symptoms mean that you have the symptoms that make you wake up at middle of the night. Those are nighttime symptoms. Commonly, patient will complain cough middle of night, wheezing at middle of night. Those are night symptoms. And number 3, you want to know, does the patient need to use reliever for the symptoms or not? Do they need to use the pump, the inhaler pump, for the symptoms? Number 4, I want to know any limitation of activity because of the symptoms. Okay, this is a 4 important questionnaire. Okay, remember this one. Common question we can ask is what type of symptoms, what question you want to ask the patient when the patient comes in with bronchial asthma attack. Okay. So if you have none of this, you have quite good control. You have 1 or 2 or even 1 night symptoms, a day symptoms, you are counted as partly controlled. If you have more than 3 or even all of them, you have uncontrolled asthma. Okay. Okay. So the asthma management, of course, we want to assess by using the questionnaire. We want to monitor and know how is the disease activity. And after we getting that assessment, the next step is to educate the patient itself how to self-management. We want them to acknowledge what is acute attack, what is stable asthma, and another thing is how do they use their inhaler. The technique of an inhaler is one of the important thing as well, because the delivering of the medication depends of the inhaler techniques. So which I will talk about in the next few slides. So and then the most important is highlight what is our long-term goal for asthma management to the patient. We want to know what is our target. Our target to them, of course, will be optimizing until no symptoms and no exacerbation. And want to highlight to them the importance of compliance to using the medication inhaler every day. Okay. So basically, in the treatment of asthma, there are 2 types of drugs that used to treat asthma. So we have, as we know just now, the pathophysiology. The main thing is there's increase in secretion due to the inflammation. And number 2, there is an increase in bronchoconstriction. So there's 2 groups of medication we will employ. Number 1 is the bronchodilator. Commonly used is beta-2 agonist, like salbutamol. So and number 2 medication to reduce the inflammation will be corticosteroids. So there are different form of steroids that we are using for maintaining of the bronchial asthma control. We are using inhaler. During exacerbation, we will use oral steroids or parenteral means IV steroids. Okay. Those are the common thing we use. Steroids and also beta-2 agonists. Okay, I think this one is just repetitive from the slides just now. Okay, so how do we manage the chronic asthma? So management of asthma is mostly stepwise approach. So after we get the questionnaire, if you know the patient control is not good, then we'll step up our control. So we have different bullets in our hand. Of course, we don't straight away use our largest bullet. We try to step up accordingly. So we tend to use a milder form of medication whenever possible, and step up if let's say the condition or the control is not good. So, um, so usually the preferred one we use low dose for management. We use a low dose inhaled corticosteroid plus formoterol. Formoterol is a bronchodilator. So in step one, usually we use a low dose steroid plus a bronchodilator for maintenance. Okay. So we only use it as needed. As needed means they have symptoms. When patient have attack or even the cough, frequent cough, wheezing, so we ask them to use when needed only. That's for the beginning control. If their symptoms is still not good despite you using it as needed, symptoms still every day, still not controlled, then we step up. Step up to every day using the combination of low dose steroid and bronchodilator. If the low dose doesn't work, we step up further. We use a medium dose. If the medium dose doesn't work, then we use a high dose. So it's a very logical step up approach. Huh? So you don't need to remember the exact name of the medication. You just need to know the principle of management of bronchial asthma. It's always a combination of inhaled corticosteroid and also the bronchodilator. So when you have attack, we also use that as needed. So we tend to, the current guideline tend to simplify everything by using one inhaler. Whether maintenance and also reliever, we're using the same inhaler for the ease of the patient. So after we step up every time, we review the patient, how is the control, assess again any other concurrent or modifier risk factor that we can change before we step up. Most important is assess the inhaler technique and whether they are using it correctly or whether they are using it or not before we adjust, increase the medication. Okay, so classification of severity, I think we talked about this one. If they have more daily symptoms, they will consider as a moderate to severe. Okay, this is just a repetitive of the previous slides. So assessment again, asking the four simple questions. If they are not controlled, you want to explore the risk factor for their poor control. Are they using? Are they keep on exposed to allergens? Do they have other comorbidities like GERD, like sinusitis that exacerbate the asthma? And we want to know whether they are using too much the bronchodilator. Those are the high risk factor for severe exacerbation. So lucky to you, you don't need to remember all this. It's just to tell you that there are different inhaler available. This is a combination of asthma medication and COPD medications. So for asthma, the commonly you see is these two. It's a salbutamol, blue color one. So patient will tell you they're using a blue color inhaler. So this is the one. So another one is the chocolate color inhaler, is the steroid inhaler. They will tell you this one. Okay. So blue color one is a SABA, means a bronchodilator. Okay. So you don't need to know exactly what are the names, what are the type. You just need to know asthma inhaler, they are blue color. They are different color, but then the way of using this inhaler is different. Okay, so this is the common that asthma patient is using. There are something called turbohaler, something called autohaler. There's something called Respimat. The method of using all these are different. That's why every time when you see the patient, we always assess again different inhaler, how do they use it? Are they compliant to it? Is the technique correct or not? So for this common inhaler, sometimes it's not so easy for young kids and the elderly because there are certain maneuver you need to use. You need to breathe in after you press on this inhaler, and then you need to hold your breath for 10 seconds. So it's not so easy for young teenager or young kids because they cannot obey command. They do not understand what do you mean, so they can't hold the breath very well. The delivery of medication is not so well. That's why we have something called spacer. So spacer is just a chamber for you to release the mist or the medication into this space, and then patient can breathe in normally through the mouth by attaching to the mouthpiece. So it's actually one of the device that can help to overcome the inadequate technique of using the inhaler. Right. So that is for chronic asthma management, the general principle. So how about acute exacerbation? So this one is important as well. Bronchial asthma exacerbation can be divided into mild, moderate, severe, and also a life-threatening bronchial asthma. So in mild asthma, mild moderate asthma, there may be wheezing, there may be tachypneic a little bit, but their oxygen concentration is still good. Okay, so they still can speak in the sentences. They can still drink water. They can still talk to you. Can still sit up and eat themselves very well. That is mild to moderate. When they are getting into severe bronchial asthma, they actually talk in just very short sentences or even just few words. Okay, they tend to be very tachypneic right now. Because the airway is too narrow, they have to breathe faster. They're starting to have hypoxemia. The SpO2 start to drop. Then they can't talk well. The heart have to beat faster, and they're starting to use more accessory muscles that you can see. Whereas life-threatening asthma, usually they'll be very ill. They even confused because hypoxia, their brain does not function very well. They'll be very lethargic. They're even agitated or confused. And you don't hear air entry. You have a silent chest. You don't hear air entry on auscultation because the airway is too narrow. There's no air getting in and out. That is life-threatening bronchial asthma. So acute management, you want to keep your oxygen more than 95%. You want to give your salbutamol, and then and you want to give corticosteroids. So in acute exacerbation, you do give if there's mild to moderate, you give oral steroid. If it's severe enough, then we give IV steroids. So for them, how do we discharge them? If we think they are well enough, they can saturate on room air when their inhaler technique is good enough, and if they can use the bronchodilator, the inhaler at home themselves, then we can discharge them. Okay, that's for bronchial asthma. Any question on asthma? Any question on bronchial asthma?
I think we can continue, Doctor.
Oh, okay. Okay, so for the next 10 or 15 minutes, we're talking about COPD. Okay, so COPD is slightly different than bronchial asthma, where the airway obstruction usually is not fully reversible. So the healthy airway is very, you have a good lumen, huge lumen for the air to go in and out. Whereas in bronchial asthma, commonly is due to a chronic exposure to dust, to cigarettes or tobacco smokes. So this lead to a lot of inflammation and mucus, and also fibrotic changes in the airway. This narrow the lumen permanently. So this airway obstruction is not very reversible. There's a difference between bronchial asthma and COPD. So this includes the COPD usually includes the conditions including bronchial emphysema and also chronic bronchitis. So emphysema means there's a permanent dilatation of the air space. Our normal alveoli is like a grip-like shape. There are different small air space here that's responsible for oxygen or air exchange. So in emphysema, all these small air space get damaged. The alveolar membranes get break down, so the airway exchange does not happen so well here. While chronic bronchitis characterized by increase in mucus. There's too much excess mucus in the airway, causing chronic phlegm production and reducing airflow. So how do we diagnose COPD? So it's characterized by the shortness of breath, where this time is tend to progress over time. It tend to worse with exercise, and the shortness of breath is persistent. It does not happen episodic. It's persistent and progressive over time. Patient will also have recurrent wheeze, and they will have chronic cough. Most of them they are intermittent, productive. They can be unproductive as well. They can have chronic dry cough as well. And of course, the prominent risk factor usually found in this group of patient will be chronic smoker. Besides the smoking, if elderly, we want to ask any chronic fuel combustion as well. In a rural area, they tend to still burning the woods, burning the fuels for cooking or for heating. Those smokes, they are potential allergens. Occupational dust, those in factories and laboratory, those that are not wearing masks. So those are the important risk factors you want to explore. Okay, so there are two spectrum of disease in COPD. One group of them that have chronic bronchitis, they keep on coughing out with large amount of phlegm. Because of this increased production of the phlegm, their bronchus is always inflamed. They always have trapped mucus. So this trapped mucus not just block the airflow, they also breeds germs, means that they tend to have infection because of the increase in mucus. And their cough usually worsen in the morning as well and during the cold weather. Whereas another spectrum, emphysema, they have permanent damage of the alveoli. This reduces the air exchange surface area. The symptoms usually is shortness of breath and persistent cough because of this. So this is just a repetitive exposure to smoke dust in the occupational hazard. And chronic smoking is still one of the most important causes in COPD. So how do we differentiate them in different airway disease? So the main difference, of course, is still the way the episodic in asthma. Asthma tend to have episodic symptoms. The airway obstruction is variable, whereas COPD, the airway obstruction is permanent, and the symptom is persistent. And of course, in asthma, they will have dural symptoms, where the symptoms worse at night and early morning. They'll have other atopic symptoms like eczema and rhinitis, whereas COPD does not have that. Asthma tend to onset earlier in childhood, whereas COPD, they only onset 20 or 30 years after you have a very heavy smoking. So they tend to present in elderly or adulthood. Okay, so there are differential in chronic cough. Always remember heart failure, tuberculosis. Those are two important differential diagnoses you need to know. So in patient with COPD, In examination, they may or may not be tachypneic. If they're in exacerbation, they'll breathe faster. They'll have something called barrel chest. What do we mean by barrel chest? So normal chest wall, your AP diameter means the front to back, your diameter is actually smaller than your lateral diameter, your left to right diameter. In the COPD patient, because of the chronic air trap, they need to breathe in harder. The alveoli is damaged. The lung cannot release that much of air out. So they will have hyper expansion of your lung. So your AP diameter will increase, so making you to have this barrel chest. So in auscultation, you also hear rhonchi. The airway will, the air entry sound will reduce because of obstructive airway. Then the investigation, of course, we want to do at least an X-ray. So in this X-ray, you notice it's slightly different than other X-ray you've seen before. You see a condition what we call hyperexpanded lung field. You see more rib space that you see in normal X-ray. The whole thing seems like it's stretched downwards. The heart becomes elongated. If you measure the ribs, there are more rib space than you see in normal X-ray. This is a hyperexpanded lung field. So the investigation for COPD, you want an X-ray. You want to check the pulse oximetry to check the oxygen level. The ABG is important here to look for oxygen level and the carbon dioxide level in your blood. And then spirometry is important as well to check for the airflow reversibility to differentiate between asthma and COPD. So if the COPD is severe enough, those emphysema patients, the airway damage should get big enough to form bullae. So normal air space alveoli, you weren't able to see it on because it's too small. But when they are coalescent together, when the airway damage big enough, they form to be a small balloon like that. So in CT scan, you see all these small air bullae here. In the X-ray, if you're big enough, you're able to see the bullae. Okay, this bullae will rupture and cause pneumothorax spontaneously. Okay. Okay, so the spirometry here, you do not need to know how to interpret them. You just need to know that in the COPD, there are airway obstruction. The FEV1 will reduce, I mentioned just now, and the FVC will also reduce. So comparatively to a normal person, your FEV1 is much reduced, FVC is reduced. It's a obstructive airway pattern in COPD. So this is the arterial blood gas I'm talking about. When you are normal blood taking that you see in the ward in the clinic, you are taking the blood from the vein because that's easier to take and less harmful, less painful as well. But in someone with hypoxia, with airway disease, we want to know the oxygen level. So oxygen level, we can only know that by taking the blood from artery because artery contain the blood that is oxygenated. Venous blood, they are not oxygenated. But we want to know the oxygen concentration. We want to take the blood from the artery. So that's what we call arterial blood gas. So there's certain there is a stats of normal range in arterial blood gas for us to analyze the certain number cutoff threshold. What is a normal oxygen level? What is a normal carbon dioxide level in the blood? That's how we interpret the test result. In someone with type 1 respiratory failure, their oxygen level is not good. So their PaO2 is low. That's what we call type 1 respiratory failure. So type 2 respiratory failure means it's not just oxygen not enough. Their carbon dioxide also not good. The body cannot expel carbon dioxide due to respiratory failure. So that's what we call type 2 respiratory failure. Okay. Just need to remember this basic concept on it. So in COPD patient, they tend to develop type 2 respiratory failure because of the air trapping. Okay. So how do we treat for COPD? So the problem is the airway obstruction. So the solution is bronchodilator. We want to dilate back the airway for gases exchange. we are using short-acting bronchodilator and also long-acting bronchodilators. So just remember the concept. You do not need to remember the name of the inhaler. You just need to remember they are bronchodilator for treatment of asthma. Okay. So again, this is the summary of types of medication we use in COPD. You notice in COPD there are more medication because as opposed to bronchial asthma, usually asthma, their inhaler tend to be responded very well, tend to be managed quite well with one or two inhaler. Whereas COPD, you need more inhaler to control them. One or two inhalers sometimes does not work so well, mostly because the allergen is still there. The compliance to avoidance smoking is not so good. So the patient will typically you use more than two inhaler to control. So you need SABA, short-acting bronchodilator, you have SAMA, you have inhaled corticosteroids combination medication. Okay. So in acute exacerbation, again you will need corticosteroids in prednisolone or IV form. You give oxygens, and the long-term management you will need pulmonary rehabilitation, teaching the patient how to breathe and increase and exercise to increase your breathing muscles ability. Those are things that we do in chronic COPD patients. Again, most important is still the lifestyle changes. Quick smoking or vaping is one of the most important things in COPD management. If you are still smoking, inhaler basically will not work. And those with chronic airway disease, vaccination is very important, especially flu vaccine and pneumococcal vaccination, because they tend to have infective exacerbation and develop pneumonia. Okay, so in asthma just now we have a classification to classify them into control, good control, or bad control, partially control or not control as well. Whereas in COPD, we have different classification, something called GOLD classification. We classify it into class 1, 2, 3, 4, or we classify into A, B, and E. So you don't need to remember this. It's just good to know. It's just a way of communication for us to manage the patient. What do we mean by GOLD, A, B, and E? So these are the classification that commonly we use. So A and classification A means that they have more than one exacerbation and their symptoms is not so well controlled. So we classify it based on the scoring here, the symptom scoring and the exacerbation scoring. So those that have exacerbation require hospitalization, automatically they will class E. So this just classification is just for us to communicate with another physician that who manage the patient that will know how bad the control is. So someone with COPD class E tell you that this patient control is terrible because they have exacerbation and they get admitted at least one or twice in the present year. Well, GOLD A tell you that control is good. The symptoms is well controlled. There's no hospitalization. That's the purpose of we doing the classification. So how do we treat COPD? So in the group E, just now we mentioned, this is the group that is not good control. They get hospitalized, they have active symptoms. We tend to give combination of inhaler. We give a long-acting bronchodilator. We give long-acting muscarinic antagonist, LABA and LAMA. It's very simple short form. LABA is to dilate the airway. LAMA is to dilate the airway and reduce secretion. And if symptom is not good control, we add on a steroid. ICS is an inhaled corticosteroids. So the component is about the same, it's just that how we combine them together. So group E, not good control, we give LABA, LAMA, and maybe add on a steroid if the control is still not good. Whereas if let's say group A, the control is good, we just need a LABA. We just need a bronchodilator. A good B control, not so good, but never hospitalized. We use LABA, LAMA enough. Okay. So the pathway is very similar to bronchial asthma. We review their symptoms. They're not good. Still have symptoms. We assess their technique, and then we escalate their medication. Okay, so it's just a repetitive management of non-pharmacological medication, non-pharmacological management of COPD. Most important, of course, is smoking cessation, avoiding all the smoke exposure. Okay, we encourage physical activity to improve their lung function, their chest muscles, and flu vaccination is one of the important components to avoid infective exacerbation. We do not want them to get infection or pneumonia that will worsen their lung function. So complication of COPD, they'll keep on coming in for lung infection. Eventually, if the lung function is bad enough, they'll have right heart failure, heart problems. They may even develop into lung cancer. Okay, that's all for COPD. Any questions? Oh, everyone is ready for photo taking.
We are ready for CNY, doctor.
So today you guys still have teaching one?
Yes,
Why
today we still have teaching.
some of you in the library, some of them not, is it?
Doctor, before that, I want to ask you, next week on Friday, we actually have class, but then you will postpone it, right, for in regards to CNY celebration.
Yeah, Friday you guys have class.
We have class, but then, yeah.
Online class, is it?
Yeah, online class.
Oh, let's see. When is Friday? Friday.
Next week.
I think Friday. Let's see. TNY. Where got people got go class on? I think none of you will be listening. Okay.
Okay, doctor, we'll postpone it.
I think we postpone it lah. We postpone it to
Okay.
Okay. Because next week lecture is TB. Is quite important. We do it the week after lah. Okay. So any question or not for asthma and COPD?
No.
No question now. So I can tell you definitely there are some questions will come up from this lecture, and because it's asthma and COPD is important. So make a start on this lecture, okay? Oh, everyone looks so happy. Can go back already. Okay, no question. I think you guys can take the attendance.
Yes, okay, we'll take attendance first. Okay, doctor, we're done.
Okay.
Thank you.
All right. Happy Chinese New Year.
Thank you,
See you guys.
Doctor.
Happy Chinese New Year, doctor.
Bye bye.